Okay, so we're going to talk about four subjects. It's going to be a small presentation. So this is going to be about a few guidelines and management plans. So the first one is going to be the acute stroke workup for wake up unknown symptoms. I'm sorry, I'm hearing somebody. The first one will be about wake up unknown symptom onset protocol. The other one is going to be about intracranial hemorrhage management. The third is going to be about post-thrombotic symptomatic intracranial hemorrhage, and then anti-coagulated associated intracranial hemorrhage. So what about wake up or unknown symptom onset stroke? So really, from the important thing from a definition perspective is last seen normal, right? So it's a definition of last seen normal. So it's exactly the time where the patient was last seen normal that where the clock starts. So if the patient went to sleep at 10 p.m. and he was last seen normal at 10 p.m., then the night before, then the last seen normal is 10 p.m. The night before. It's not the time when. So if he woke up, let's say at 7 a.m. with the symptoms and he arrives at the hospital at 9 a.m., the last seen normal is considered 10 p.m. from the night before. So the protocol is based, so the treatment or the treatment algorithm protocol is that the fact that IV can be effective for patients selected based on MRI selection. And MRI selection is based on a mismatch between flare and DWI. DWI shows acute stroke, and flare usually becomes positive 6 hours after the infarct. So there's a class 2A, a level of evidence B, from guidelines from 2019 that treating wake-up strokes with the mismatch on imaging show potential benefit. So about 20% of strokes are detected upon awakening. Usually they were excluded from IV lytic treatment due to being out of the window. Radiographic studies suggest wake-up stroke likely occur shortly upon awakening. A randomized study showed efficacy of IV TPA within 4.5 hours of symptoms detection, selected by MRI of the brain for independent outcome. This applies to patients with stroke symptoms who were last seen normal is more than 4.5 hours prior. So what do you do when you have these patients? You obviously do the exam, you do the history, you obtain a CT, and then you obtain an acute stat MRI with DWI and flare. If you have a DWI lesion less than 1/3 of the MCA territory and no visible changes in flare, then you monitor, you give IV lytics. And the studies were based on IV TPA, obviously, but now we're using TNK, and it's the same rationale. Patient with wake-up, unknown symptoms, onset stroke, can receive potentially live treatment with IV alteplase within 4.5 time window, improve the odds of their independent outcome. The number needed to treat is 9, with symptomatic hemorrhage rate only of 2.4%. This obviously will increase the chances of good outcome and increase the likelihood of the patient getting treated. For patients who were excluded from treatment. So from management perspective in the ER, if you have a wake-up stroke or unknown last seen normal, if their VAN is positive or MRI not available, you do a head CT, CT perfusion available, and CTA head and neck. If they're LVO positive and there is CTP mismatch or no large stroke on CT, then patient goes for mechanical thrombectomy if they are candidates for treatment. And obviously, if there's no mechanical thrombectomy, then they get transferred to another hospital. If they are LVO negative and they are wake-up stroke, and they are within the 4.5 hours from waking up, you do a stat MRI. If there's DWI negative or flare signal changes, so you're already seeing T2 flare changes on MRI, then you don't treat them. If the DWI is positive and you don't see a flare abnormality that you can already see on MRI, then you go ahead and treat the patient. Any question on wake-up strokes? Can you guys hear me? Hello?
Yes, Dr. Elkhory, we can hear you loud and clear. That's very helpful. Thank you.
No, absolutely. Thank you very much. Okay, so we're going to talk about intracranial hemorrhage. Very common, about 15 to 20, depending on the center, it's about 15 to 20% of all acute stroke presentation. The clinical presentation is very similar to ischemic stroke. Most common cause of hemorrhage is hypertension. Usually patients have a history of hypertension or come with very high blood pressure that needs to be treated acutely. There is a risk. The main risk of hypertensive hemorrhage is expansion. They can expand rapidly, quickly. This is why patients needs to be in a high level of care center. This is why they need to be seen by neurosurgery in case they expand. And this is why they need to be monitored very closely in an ICU setting. There is a predictor of mortality on these patients. It's called the ICH score, and you have it here on your right side. The scoring is depending on GCS. If you're 3 to 4, you get 2 points. 5 to 12, you get 1 point. If you're doing better, 13 to 15, you have 0 point. If you're older, you get a point. More than 80, depending on the location, you get a point as well. Supratentorial or it's in a smaller space, so usually patient do worse. Depending on the volume, you get a point. And intraventricular blood, if you have intraventricular blood, you get a point. And the higher your ICH score, the more likely you have higher chance of mortality at 30 days. And this is a good predictor. This is mainly used in the ICU setting, less a little bit in the ER, but you can know that how the patient are going to do based on the clinical presentation. Imaging, obviously, CT is the gold standard. You do CAT scan, you see bleed. You do CTA, CTA head and neck. There's few studies, there's something called a dot sign. If you see a little bit more contrast in an area inside the seat where the bleeding is, then there's more likely chances of expansion. Also, the use of a CTA is obviously in bleeding is not to look for large vessel occlusion, but to look for other etiology of bleed like arteriovenous malformation, like aneurysm. Recommendation for management, we don't recommend platelet transfusion unless the patient has low platelets. It comes in with, let's say, platelet level of 40, 50. Then we recommend transfusion, reduce blood pressure as much as possible. Obviously, don't drop it very quickly, but the target should be between 130 to 140 systolic to decrease the risk of expansion that's associated with high mortality. IV nicardipine is the most frequently used. Other options, labetalol, hydrazine, and anapril. Usually the recommendation is to keep the head out of bed 30 degrees, but if you need to transfer the patient or you need imaging, then you can't put the head flat. Seizure medication is not recommended. It's associated with worsened outcome. Obviously, you need to treat glucose if the patient is hypo or hyperglycemic, cardiac monitoring, and frequent neurochecks and vital signs. Consult neurology and neurosurgery, and then if there is any neurological worsening, increase in stroke scale, repeat CT is recommended. ICH, emergency need frequent monitoring and watch for expansion. Now, another type of hemorrhage that we fear, and we need to discuss a little bit of what are the treatment options. What do you do post-TMK or post-TPA bleed? Sometimes you can have small hemorrhagic transformations that's really are asymptomatic. You do a follow-up CAT scan, you find a little bit of blood. You found a little bit of blood, and really nothing to do. But unfortunately, some of them the patient can bleed post-lytic or post-thrombectomy, and they can have much worsened outcome. So what is the first-line treatment for this? Really, the only first-line treatment post-TPA is but really the level of evidence is 2B, right? We don't have a lot of data. It's cryoprecipitate. You give 10-unit infusion over 10 to 30 minutes, and then you administer additional dose. You monitor it with fibrinogen levels, and you check it every 30 minutes, and your goal fibrinogen it should be between 100 to 200. There's some data on tranexamic acid and aminocaproic acid that inhibit plasmin. Say that support efficiency of either is really is very limited. And if you don't have any options for this, transfusion of 8 units of platelets is reasonable as emergent transfer to higher level of care. Any question so far on ICH and post-lytic treatment?
Nothing so far. We don't have any questions.
Thank you. Okay, fourth discussion that I want to discuss is anticoagulation associated intracranial hemorrhage. So this is the patient that comes to us who are on warfarin, who are on dual antiplatelet therapy, who are on newer anticoagulation like Xarelto, a little bit older like Pradaxa. Really the message here is those patients are associated with worsened outcome than your typical hypertensive bleed that are not on blood thinner, and you need to monitor these patients very closely. Imaging wise, very similar to the management of ICH. You do initially a CT head non-con, and then you do a CTA head and neck. Try to see if there's any spot sign, to see if there's any underlying vascular malformation to manage the patient. A recommendation from a management perspective: keep blood pressure lower. Don't drop it very fast, but try to target a blood pressure of 130 to 140. There's really no magic formula to this, but if somebody comes in with systolic of 220 and you want to drop it to 140 systolic, I'll probably take 3 to 4 hours. Obviously monitor the patient. If they become symptomatic, then I would not drop it very quickly. Keep the head of bed elevated to 30 degrees, excuse me. Do frequent neurochecks, 0 to 6 hours initially, to look for any neurological deterioration. 6 to 24 hours every 1 hour, and then depending if there's any important. Yeah. Oh, okay. And then monitor more closely if there's any risk of there's any deterioration. Control neurology, any surgery. Document the severity of the SCH with the ICH score that we discussed earlier. Do not give anti-seizure medication unless you're suspicious for seizures or you saw a clinical seizure, like you see the patient seizing in front of you. Obviously, you need to treat. Cardiac monitoring and monitor their glucose level. This is a nice slide from the 2022 guidelines. Those are the blood thinners that are commonly encountered that are associated with ICH. And this is the treatment recommendation for this. If you have Coumadin or warfarin and their INR is between 1.3 and 1.9, then use 4 units of PCC, 10 to 20 units per kilogram. It's a class 2 recommendation. If the INR is more than 2, then I use 25 to 50 international unit per kilogram. And this is class 1 recommendation and IV vitamin K. If they are on pills, if they are on NOACs like dabigatran or factor 10A inhibitor, we ask them the time they use it. If they use it, depending on the lifetime of your newer anticoagulant, if some of them can be 48 hours. If it's more than that and they haven't taken it for a week, for example, then obviously I wouldn't reverse it. If they took the medication within 2 hours, then I would consider activated charcoal. If they took dabigatran, then the treatment option is idarucizumab. You can give it as a class 2A recommendation. You can use PCC or renal replacement therapy as well if idarucizumab is not available. And then for other medication like Xarelto, treatment available is andexanet alpha. It's a class 2A recommendation. Also for heparin, if they are on unfractioned heparin, you can use protamine. It's a class 2A recommendation. And then if they are on low molecular weight heparin, you can use as well protamine, but in this case, it's a class 2B recommendation. Those are the treatment options that you can use for the patients for anticoagulation related bleeding. Important to recognize, important to treat as fast as possible. And then if we don't have some of this treatment available in the hospital, obviously transfer is an acute recommendation. Any question on these 4 subjects?
I think
Nope, that was great.
Absolutely, absolutely. And Amy, I'm going to share the slides with you.
Okay, that's perfect. We'll send it out with the
If you want.
yes, thank you for anyone who didn't attend. Thank you all for taking the time to attend this afternoon. Appreciate it.
Thank you very much. Thank you, everybody.
Thank you.
Thank you, Dr. Elkhory.
Absolutely, thank you. Absolutely.
everyone have a good day.
Thank you,
all.
Dr. Elkhory.
Thank you, Dr. Elkhory.
Have a good day. Bye-bye.
Thanks. Bye-bye.